Trauma patients die for a variety of reasons. If there is immediate death in trauma, it's usually due to either massive head trauma or aortic disruption. The delayed deaths in trauma are the ones that we potentially could make a difference in. Those are patients who hemorrhage, patients who develop a coagulopathy for a variety of reasons, the patients that get acidotic, and those patients that become hypothermic. It's the delayed hemorrhage and delayed deaths that we're attempting to make a difference in by the administration of TXA. Anytime you have hemorrhage in trauma, you have several things happening, usually all at once. Your platelet activation in order to plug up any bleeding holes that may be present in blood vessels. You also have the coagulation factors that come together to produce thrombin, which is ultimately converted from fibrinogen into a fibrin clot that again helps plug up holes. Anytime the body perceives that there is clotting going on for whatever reason, it initiates a process called fibrinolysis. This is where you have a clotting factor known as plasminogen that's converted to plasmin that helps to break down the active clots. This is what we call the acute coagulopathy of trauma. And it is this lysis, this clot lysis that's happening that we are trying to intercede in hemorrhage patients with TXA by using TXA. Well, tranexamic acid, TXA, is an antifibrinolytic. As I said on the previous slide, there is plasminogen that's converted to plasmin, which helps initiate clot lysis. Well, TXA tries to inhibit plasminogen activator and plasmin together. It prevents the body from breaking down clots and thereby tries to achieve a manner of hemostasis. It does not promote new clot formation, which is an important point to know when you think about trying to give TXA in a hemorrhaging trauma patient and you're worried about initiating either a pulmonary embolism or a myocardial infarction. We had an older drug called aminocaproic acid, and in fact we still use that sometimes in patients who are hemorrhaging for different reasons. TXA is 10 times more potent than aminocaproic acid. The half-life is about 2 hours. That's why after you initiate the bolus, a maintenance drip is usually required. And this drug is prime for EMS usage because it can be stored at room temperature. We don't need to refrigerate it. Let's talk real quickly about the CRASH-2 trial that was designed to look at the efficacy of TXA. This is the clinical randomization of an antifibrinolytic in significant trauma. And it was a significant trial that showed the importance of initiating TXA administration in trauma patients, and one that we base a lot of our presumptiveness of using this drug in the pre-hospital setting. Well, CRASH-2 was performed in 274 hospitals in 40 countries. The United States was not instrumental and was not a part of this study, but it has since come to adopt a lot of the findings out of the CRASH-2 trials. In this trial, they used over 20,000 adult trauma patients who had or was at risk of having significant hemorrhage, and they either had a heart rate greater than 110 beats per minute, a systolic blood pressure of less than 90, or both. And treatment was initiated within 8 hours of initial injury. Here's where this trial gets a little confusing, but I'm going to boil it down for you that the primary reason that we're using TXA is because of the great success they had in this trial. The patients that received TXA or placebo, they looked at their all-cause mortality. In other words, everything the patient may have died from, okay, related to their trauma, whether it was organ failure, whether it was a head trauma, whether it was hemorrhage. And what they found was that 14.5% of the people who received TXA, either in the field or in the hospital, most of them in the hospital, were more likely to survive. This was compared to 16% who received placebo. So you can see that's a 1.5% risk reduction. Now, I'm not going to get into a lot of the statistics that were involved with this, but this was a statistically significant study that showed that TXA was superior to giving nothing, okay? There's a term in statistics, especially medical statistics, that we look at called the number needed to treat. And of course, the lower number that you see, the better that the study was, and the more efficacious the therapy was in helping whatever condition you're looking at. In the CRASH 2 trial, the number needed to treat was 67. You need to treat 67 patients to save one life. Now, I know that doesn't sound like a great outcome. However, a lot of the other studies are hundreds and hundreds of patients that you need to treat to save one life. And so considering the fact that TXA in the realm of medications that we might use is rather inexpensive, the number needed to treat of 67 to save one life is very reasonable and is very important to understand. There was strong evidence that survival was related to the time of injury to treatment. If you received TXA less than an hour after your injury, great results. If you received TXA between 1 and 3 hours, which were the parameters they looked at, again, great to good to great results. Greater than 3 hours, not good. A lot of those patients, there was actually shown to be a higher rate of death, and they don't exactly know why this is right now. They're looking at this very closely. So that's why our primary recommendation is you need to have sustained, the patient needs to have sustained the trauma less than 3 hours in order for TXA to be a good modality to use. Well, what about harm? They did look to see if patients developed any sort of thromboembolic or vasculo-occlusive events, such as MI or PE. And again, while they determined that TXA was not suspect in patients who developed these life-threatening conditions after trauma, they did have some patients who did have thromboembolic events. A lot of these patients had a previous history of this. However, when they looked at their rates between placebo and giving TXA, they determined that the rate was 1.7 of patients, 1.7% of patients who received a placebo versus 2.0% of patients that received TXA develop a thromboembolic event. When you look at the numbers, literally the numbers of greater than 20,000 patients in this study, they determined that this amount of thromboembolic events was not clinically significant. The bottom line is, in this massive study that was performed with over 20,000 patients, the bottom line is TXA did not reduce the need for blood transfusions. It did not reduce the need for surgery. It doesn't tell you whether your patient requires surgery or not, but it did increase overall survival. That is the prime objective in this in using this medication. A few other points regarding the conclusions of the CRASH 2 study was that TXA reduced mortality in bleeding trauma patients. It does not seem to increase unwanted clotting. It needs to be given early within 3 hours of injury, and again, as I said before, it is not expensive. These things all put together make it a great modality to include on the ambulances for paramedics to use in trauma patients. As we all know, trauma patients, there's not a lot of things pre-hospital that can be done. A lot of these patients may or may not require surgery, but they require higher levels of care than can usually be given pre-hospital. This is one thing that will help bridge a lot of those patients and may help you to save a life or two while you're transporting them. There was another important trial that looked at using TXA in the military. This was the MATTERS trial that was studied in some combat hospitals in Afghanistan using military personnel who underwent blunt and penetrating trauma. And quickly in this study showed, again, just like in the CRASH 2 study, that TXA was a prime deal maker in stopping hemorrhage in a lot of these trauma patients. And even though that the civilian population that you and I see on a day-to-day basis that's undergone trauma are not similar to what combat troops endure, bleeding is bleeding is bleeding. And TXA was shown to be very helpful in the military use in which in the setting that they were in for stopping hemorrhage in these trauma patients. And again, it just gives us more evidence that we are headed in the right direction in using TXA in trauma patients in the civilian population. Okay, now down to the protocol aspect of administering TXA. In the protocol that you are going to be reviewing and are responsible for knowing, the indications for use of TXA in trauma patients are these: adults with known or suspected major hemorrhage. We're not talking about the fender benders. We're talking about major hemorrhage, intrathoracic, intra-abdominal, or long bone fractures. The patients need to have a systolic blood pressure of less than 90 or a heart rate greater than 110 or both. And as important as the other two aspects are, the time of injury needs to be less than 3 hours. If you get a call at 3 a.m. To go to someone's house and they're having severe abdominal pain and they're hypotensive, and someone tells you they were in an automobile accident the night before, 6 hours, 7 hours, 8 hours, whatever it is, and you suspect that they have internal hemorrhage, you cannot administer TXA. It has to be given in less than 3 hours from the time of injury. So you need to document this fact, particularly because patients who are given TXA at greater than 3 hours out from the time of injury have a worse outcome, and we don't want that to happen. They can certainly die or have more morbidities after 3 hours that could be something that is not related to the administration of TXA, but you don't want that to be called into question. Our contraindications are, right now we are not going to be using this in pediatric patients. Any patients less than 18 years of age. It's not been studied or proved in that age population. We don't want to use it in isolated head trauma. It's not going to be helpful. Patients don't hemorrhage with isolated head traumas. Even it being a gunshot wound to the head, patients are not going to die due to the amount of hemorrhage from a gunshot wound. So isolated head traumas, do not use TXA. We prefer you do not use it in patients who have known thromboembolic disease. You almost will never know this aspect of the patient's history prior to making the decision to give TXA. But if you do, it would be better that you do not give it to a patient who was recently diagnosed with pulmonary embolism. We do not need that aspect. There's a lot of other ways we can intercede on a hemorrhaging trauma patient if you cannot administer TXA in a field because of this reason. Certainly known hypersensitivity to the drug. We will never know this in a patient unless you just happen to pick up the odd patient who had previously received tranexamic acid for a previous trauma or another reason to give the drug, such as a hemophiliac patient. But you will almost never know this. But if you do, that is a contraindication using the drug. And certainly no IV access. The drug has never been shown to be helpful, has really not been studied in using it intraosseously, certainly via endotracheal tube. So you have to have good IV access in order to administer this drug. Well, that's it on the administration of TXA. I hope you will find that this drug is very helpful in trauma patients. Again, you may not see the end result in the ambulances, but there's a lot of things that we do in EMS that we don't see the end result until after the patient reaches the hospital. If you have any questions, please don't hesitate to contact me or your operations supervisors or field supervisors regarding the administration of TXA. Thanks very much.